it's time to start. I think 2-3 more people will come in. All right, we shall start. And this is an absolute revision for you guys, because you're all really thinking 1.5 months you're hearing about hematology and the red cell and the white cell and the platelet and this anemia and that anemia. We are going to sum it up here. So I hope you like what you see and you revise. Like I told you, I will be making a quiz for you, and the quiz will come to you on your emails. So take a look out for it. So here we go. It says, by the time you finish reviewing this presentation, you will be familiar with. See, somebody's coming in. Who's coming in? Don't you have something that you can just take them in? It's very irritating. Who's coming in? Somebody else should join. Done? Alright. Sorry guys, this is going to happen a couple more times. I know it's irritating and it irritates me more. Alright. So we said by the time you finish reviewing this presentation, hopefully you will be familiar with the concepts of basic hematology, the formed elements of blood, the red cell, white cell and platelets. You will review and understand different anemias like acquired anemia and inherited anemia. You will be familiar with various hematological terms, and I think you are now. You will be able to relate results from our hematological machines to the patient's sign and symptoms, enabling your pathologist, your client, to make an easy diagnosis. Individual presentations of each formed elements of blood cells, white cells and platelets. That's the reason why I said this is a revision. So the first question we asked you in the first slide is, what is hematology? And the definition was, it is the study of formed elements of blood, the red cell, white cell and platelets. It is the study of blood, the blood forming organs and blood tissues. So some of you may be a little bored with this, but let's go through it anyway. So we come to a topic called anemia, which is very much related to hematology and so very common in our country. So hematology includes the study of etiological diseases, diagnosis, treatment, prognosis and prevention of blood diseases that affect the production of blood and its components, such as blood cells, hemoglobin, blood proteins and the mechanism of coagulation. I think we've taken a look at that. So here you have a picture of the red cell. And you know the red cell, your hemoglobin is a protein. So you have a cell membrane, you have a biconcave disc 7 to 8 microns, and the thickness is 1.5 to 2.5 millimeters. And you know how important the bone marrow is in the formation of the red cell, white cell and platelets. The long bones and the flat bones. So usually when a bone marrow is done, I'm sure all of you have seen it, is the doctor takes it from the sternum. You can take it from the femur also, but usually in an adult, the sternum is preferred. Right? It's flat, it can be supported, and it can be pierced by a special needle and syringe. And again, a very quick revision: 6 stages of red cell development: rubriblast, prorubicide, rubricide, metarubricide, reticulocyte and the erythrocyte. And you can see the maturation on the right hand side. I hope the revision brings fresh ideas and scenes to your mind, okay? So here we come, the development of the rubriblast, the large cell, 12 to 15 microns in diameter, and has a large round purple nucleus which occupies most of the cell. And then as the cell matures, it becomes smaller from 12 to 15 microns to 6 to 8 microns. And like you said, you can see that there is no nuclei. So I don't want to go into every cell. So this is prorubricite stage 2. Size is more or less the same. And now you find that the nucleus becomes from finely reticulated to coarse, and you have your rim of cytoplasm down to it, right? We'll very quickly go through it. Then you've got the rubricite, still about the same size, and the nucleus, there are a lot of changes in there, irregular clumps, no nuclei, loli. Cytoplasm is blue-pink, polychromatophilic, the pink being the first signs of hemoglobin. There is no cytoplasmic granules, right? Next is the metarubricite. The cell is smaller, coming back to 8 to 10 microns. The chromatin is usually uniformly dense. The cytoplasm appears as a white band around the nucleus. It is buff pink in color, and hemoglobin is present in full amount. There are no granules present. Ideally, if you have an atlas at home, you still have it from your old days of DMLT and DCA, take a look at it. It's worth taking a look. So then you've got the reticulocyte. The cell is about 8 to 9 microns in size and does not have a nucleus. The cytoplasm is stains pinkish, buff with bright stain, and there is no central pallor, as in the more mature cell. With supravital staining, in the living stage staining, this cell will show light blue reticulum strands in the cytoplasm. It's quite interesting, and I think Jaldeep will be telling you more about this, especially on your machines also. And then of course you've got your erythrocyte. There's a mature red cell, averages 7 to 8 microns. The cell is biconcave, and this causes a difference in the intensity of the cytoplasmic staining. It has no nucleus. The cytoplasm of the periphery of the cell is buff pink, white, and the center zone is less intensely stained. So here at the bottom you have the normal ranges. Female is 4.2 to 5.4 cells per microliter. Male is higher, 4.7 to 6.1. Infants are 5 to 6.3. And I have made a note here that the Indian reference ranges are slightly lower because of our social economic conditions and way of living, diet, etc. So we come to anemia, which is not a disease. I think it's a condition of being. That's what I've always called it. So anemia is a disorder characterized by the reduction of oxygen carrying substance in a certain volume of blood due to reduction below normal in the number of red cells per microliter in hemoglobin concentration and in hematocrit. So here you can take a look at the normal red cell, and you've got the anemic red cells, and take a look at the right hand side, extreme right hand side. Take a look at the cells. You can see the hypochromic, they've got poikilocytosis. Look at the different shapes. You can see some target cells. You can see schistocytes, little fragments, and different anemias will give you these pictures. And it is really, really very interesting. So we come to different types of anemias. So anemias can be acquired.
Rose, the slide seems to be frozen, so I can't see it. So probably you might.
No. This is what happens, Jagdeep, with this. So you've got the PPT in front of you, and they all follow that.
Achha,
So
okay.
my apologies.
Okay.
Or
So,
if you can give us a trick where you can see both sides, please let us know.
no, what you have to do is you have to change it into presenter mode. So when you go into slide presentation mode, I think then the slides might change. I'm not sure.
Because we have had this problem before, and my audience has been very, very kind, and they follow the PPT which is in front of them.
So I'll follow the people.
Okay. So we come to anemias, acquired anemias, which are acquired due to some reason, and inherited is what you're born with. So most common acute post-hemorrhagic anemia, most common will come later, chronic post-hemorrhage, as the name tells you, vitamin B12, pernicious anemia, aplastic anemia, iron deficiency anemia. And the inherited, the most common ones are sickle, thalassemia, and G6PD. So, as the name tells you, acute post-hemorrhagic, when you have a sudden loss of blood. Chronic is when you have a slow bleed, you don't even know. B12 is, you need B12 for the maturation of the red cell. So the morphology changes. Pernicious, as the name tells you, bad, due to various factors. Then you got aplastic, where you have the complete stoppage of the red cell, white cell, and platelets due to a shock or exposure to radiations. And then you've got your iron deficiency anemia, which is very, very common. Correct? The morphology of cells become important. Symptoms, causes, and prophylaxis of anemia. Symptoms are anemia, signs and symptoms are varying depending on the cause. If the anemia is caused by a chronic disease, the disease can mask them, so the anemia might be detected by tests for other conditions. Depending on the causes of your anemia, you might have no symptoms. Signs and symptoms, if they do occur, might include fatigue, weakness, pale or yellow skin, irregular heartbeats, shortness of breath, dizziness or lightheadedness, chest pain, cold hands and feet, headaches. So your doctor, can you see the picture on the right hand side? You can see when you go to a doctor and give him these signs and symptoms, he is going to take a look at your eyes as well as your tongue. Alright? Causes, anemia occurs when your blood does not have enough red cells. This can happen if your body doesn't make enough red cells. Bleeding causes you to lose red cells more quickly than they can be replaced. Your body destroys red cells. So here you've got the causes of anemia, genetic factors causing anemia, excessive bleeding, menstrual bleeding, iron deficiency, cancer causing anemia, impaired metabolism of spleen and anemia. Because your spleen does take care, because when the red cells, white cell platelets are broken, who gets rid of it? Spleen. And when there is excess breakdown of red cells, your spleen is enlarged. So the doctor may palpate and they come to a conclusion, yes, you have a problem. Prophylaxis treatment. Many types of anemia can't be prevented, but you can avoid iron deficiency anemia, vitamin deficiency anemias by eating a diet that includes a variety of vitamins and minerals. So iron-rich foods, which is beef, other meats, beans, lentils, and so on. Folate, this nutrient and its synthetic form folic acid can be found in fruits and fruit juices, dark green leafy vegetables, and so on. Vitamin B12, the food rich in B12 includes meat, dairy products, and fortified cereal and soy. Vitamin C, foods rich in vitamin C include citrus fruits and juices, peppers, broccoli, and so on. So your diet becomes very, very important, and you have a picture of what you can eat if you have the anemia. So your iron-rich foods are soya bean, oatmeal, raisins, eggs, shellfish, green bread, red meat, chicken, turkey, green leaf, and so on. And the whole variety of green vegetables are on the left-hand side. Okay. Iron deficiency anemia, very, very common. When iron loss exceeds iron intake for a long time, enough to deplete body's iron stores, and insufficient iron is available for the normal rate of hemoglobin production, this is known as IDA. IDA is characterized by decrease in hemoglobin, hematocrit, and is hypochromic microcytic small cells. About 60% of iron's body is in hemoglobin of circulating red cells, and 3 to 4% is present in enzymes, and myoglobin. The rest is stored as ferritin, submicroscopic particles of iron, and as hemosiderin. So here you can take a look at the normal smear on the left hand side, and the abnormal smear you can see the hypochromic microcytic type of cells on the right hand side. Continuing with IDA, transferrin is an iron binding protein that transports absorbed iron, 20 to 25 milligrams of iron, is returned to body iron store, and less than 1 milligram of iron is lost daily in urine, bile and other secretions. It occurs when there is increase in need of iron, example during infancy, pregnancy, excessive loss of blood due to hemorrhages, excessive menstruation, lack of iron in your diet, and an inability to absorb iron. Microscopic examination shows hypochromic microcytosis, poikilocytosis, change in shape, and anisocytosis, change in size. So guys, I hope that these terminologies are very clear in your mind now. Chemical examination shows decreased iron, increased iron binding capacity, increased serum copper and protoporphyrin, and all this can be assayed in the lab. If you take a look at the pictures below, you will have a very good idea of what I am talking about. So you've got iron storage, iron RBC plus muscle, you've got ferritin, and you've got iron loss. So sweat, urine, bile, and so on. Alright. Continuing, WBC count is normal or slightly lower. Relative lymphocytosis, granulocytopenia, few hypersegmented neutrophils may be present. In the marrow, normoblastic hyperplasia occurs in early stages. Guys, I hope you're familiar with the term relative lymphocytosis, where your neutrophil is knocked down and lymphocytes appear higher. Granulocytopenia, so your granulocytes are decreased. Few hypersegmented neutrophils, these are immature cells, there are 3 to 5 segments in a neutrophil. Here it can go up to 5, 7, 9. And in the marrow is normoblastic hyperplasia. So a lot of normoblast, immature cells, red cells are present in the early stages. The normal range for serum iron is 75 to 150 micrograms of iron. Lower levels indicate IDA. The normal range of SIBC is 250 to 400 micrograms. Increase will lead to IDA. So this is a compensatory mechanism. Sometimes somebody's coming in. Just a moment, guys. Somebody's getting in. Okay. All right. So we'll go further. So you have a blood picture here. Pretty interesting. So you got peripheral blood smear of iron deficiency anemia. So you can take a look at your red cells. They are hypochromic, less hemoglobin. Center is pale. There is poikilocytosis. You've got them in different shapes and sizes. And you've got a lymphocyte at the right hand corner below. And you've got the marrow in iron deficiency anemia. You can see that the normoblasts have increased. B12, vitamin deficiency anemia is a lack of healthy red cell caused when you have lower than normal amounts of certain vitamins. Vitamins linked to vitamin deficiency anemia include folate, vitamin B12 and vitamin C. Vitamin B12 has two groups, one planar group and the other being nucleotide group. It is also synthesized by the microbes. It is found in all animal tissues and is stored primarily in the liver. Liver contains about 1 to 2 micrograms of. So here you've got the symptoms very similar. Weakness, fatigue, dizziness, vision problems, mood swings, forgetfulness, pale skin, breathlessness and weight loss. And the sources rich for vitamin B12 are, you can see, egg, milk, fish, cheese. And I think that's liver up there. So in this deficiency, it is the coenzyme of vitamin B12 is released by digestion of proteins and is bound by gastric intrinsic factor essential for absorption. So please understand this. There are two bits coming into play. This vitamin B12 intrinsic factor complex then adheres to specific receptor sites on epithelial cells of ileum where vitamin B12 is absorbed. Daily requirements of the body is 2 micrograms per liter. Its deficiency is produced due to inadequate intake and defective absorption of intrinsic factor, which is the most common cause of this deficiency. And this is quite interesting. If you take a look at it in detail, it really is really interesting. So you've got red cell formation, you've got 3 pictures down there, you've got neurological functions because it affects certain of your nerve cells, and you've got DNA synthesis involved. So we've got vitamin B12. Let's see, you can prevent some forms of vitamin deficiency anemias by choosing a healthy diet that includes a variety of bloods. Foods rich in folate include dark green leafy vegetables, nuts, enriched grain products, and so on. Foods rich in vitamin B12 include, you got eggs, fortified foods, and all that. So I always tell my students, besides being a medtech, you'll also have to be a dietitian, because mostly, patients ask you, what do I eat, what shouldn't I eat, what can I eat, and that becomes important. So I've told you I have a presentation on B12 as well as folate and ferritin. So if you're interested, we can do that a little more in detail. This I have just given you a summary. So severe vitamin B12 deficiency mimicking thrombocytopenia purpura. So you can see the red cell survival is down. Pancytopenia, platelets are also down. MCV is concurrent with microcytic anemia and deficiency thalassemia traits. So take a look at the picture. You can see microcytic cells. You can see a little polychromasia. You can see poikilocytosis. And you've got, I think, a few schistocytes also thrown in. And you've got polychromasia. On the right hand side, you've got megaloblastic anemia, large cell, and megaloblasts are present only in the blood marrow. It is not present in circulating blood, but here you may get to see it. And can you see the hypersegmented neutrophil over here? And on the other side, you've got the normal red cell. So here you see the red cells are large, hypochromic, macrocytic, and you've got hypersegmented neutrophils. So then you've come to pernicious anemia. As the name tells you, pernicious, bad. It is conditioned nutritional deficiency of B12 caused due to failure of gastric mucosa to secrete intrinsic factor. Anorexia, malaise, all those regular signs and symptoms are there. Pallor of the skin, jaundice can be observed, tongue is sore, and so on. It involves 3 systems, so keep this in mind: the gastrointestinal tract, the central nervous system, and the hematopoietic system. So this becomes very interesting. The GI symptoms are prominent, which include episodal abdominal pain, constipation, and diarrhea. So you think, oh, I've got a bad stomach. Irregular degeneration of white matter is observed, and in advanced cases it affects the brain. And patients show irritability, emotional instability, changes in personality, and we call it megaloblastic madness, because these megaloblasts are known to lodge in the spinal cord and cause all these symptoms. And like I told you, it's very interesting. Your gastrointestinal system is involved. You need the intrinsic factor, which is missing, which is there, and the B12 comes from outside. So for the B12 to be absorbed, you need the intrinsic factor, and if intrinsic factor is not functioning properly, your B12 will not be absorbed. And there are various tests you can use. Previously we used to do the gastric analyses, and we used to titer the free and the radical HCl. And now we also have certain RIA tests that we do, and we look out for it. Quite interesting. And of course now you've got the assay, and the assay tells you right off the deficient or normal. So this is the same slide, right? Hypersegmented neutrophils and so on. So coming back to pernicious, the hematopoietic system shows pancytopenia, complete stoppage of red cell, white cell platelet, decreased in all forms of elements of blood. And guys, this is bad, you know. When your red cell stops to mature, the white cell stops to mature, and platelet, then you're in trouble. Peripheral blood shows macroovalocytes, and anisocytosis, and poikilocytosis. You know the meaning. Aniso, change of shape, size, sorry. Poikilo is shape. Microcytes, small cells. Teardrops, basophilic stippling. Multiple Howell-Jolly bodies, and megaloblasts may be seen. So something new here, basophilic stippling. So in your red cells, you'll be able to see stippled red cells, little black blue dots. Howell-Jolly body is a remnant of a nuclear material in one part of your red cell. And megaloblast, as the name tells you, large cells which usually stay in the marrow. You may be able to see it in the peripheral blood. Bone marrow is hyperplastic. Fat is replaced and red marrow extends into the long bones. The normal myeloid erythroid ratio is 3:1, but here it approaches 1:1. So it is your myeloid cells that are not functioning the way it should. So patients with pernicious anemia have histamine refractory achylia and achlorohydria. Gastrophic atrophy, that is cells dying, is also observed. It can be tested by the Schilling's test. Invasive tests are not advised now. So your gastric analysis previously, a patient was made to swallow the tube down to the stomach, and the gastric juice was extracted, and then we used to titrate it for hydrochloric free and total free hydrochloric acid. And then of course you have the Schilling's test, which I told you it depends a little bit on RIA as well as the other methods, but we do not do gastric analysis anymore. Schilling's can be done. So blood smears, presence of Howell-Jolly bodies, nuclear remnants, you can see it in the middle slide. Low retic count, normal to low CR. Pancytopenia, such as thrombocytopenia and leukopenia. Marked anisocytosis, high RDW, red cell diameter width, and poikilocytosis. And I think Sandhya will be able to tell us more about it in her lecture, RDW. Take a look at the picture A. So you've got your hypersegmented neutrophil, you've got oval macrocytes. In B, you've got Howell-Jolly bodies. And again, in the right-hand side, you've got hypersegmented neutrophils. Take a look at your red cells also. They're hypochromic, microcytic, macrocytic, some schistocytes, all that is present. Huh? So we come back to aplastic anemia. As the name tells you, refers to pancytopenia associated with hypercellularity of bone marrow. So that is severe reduction in the amount of hematopoietic tissue, which results in deficient production of blood cells. Aplastic anemia is a condition that occurs when your body stops producing enough red cells. Aplastic is complete stoppage of production of cells. The condition leaves you fatigued and more prone to infections and uncontrolled bleeding. Has to, right? The WBCs are down, so you're prone to infections. Your platelets are down, uncontrolled bleeding. A rare and serious condition, aplastic anemia can develop at any stage. It can occur suddenly or it can come on slowly and worsen over time. It can be mild or severe. Marrow may have patchy areas of normocellularity and hypercellularity. I had a case many years back in America. We had this young guy, about 24, 25, coming into the emergency at in the evening. He was an army guy, and we found this blood picture which we didn't like. So I called my big boss, Dr. Evelyn Kunrad, who was one of the best oncohematologists in North Carolina. I called her, I said, ma'am, if you're on campus, just can you come see me? And she did, and she took a look at the slide, and she said, Bruce, it's a case of aplastic anemia. Let's really down. The guy was 6'4" with no energy, so we admitted him. I won't tell you the name, and he was treated by Dr. Kunrad. And she used to tell us, she says, the only thing with aplastic anemia, I get very scared because aplastic can swing on the other side into a leukemic condition. The bone marrow suddenly becomes active and produces uncontrolled red cells, white cells, and platelets. And I was looking at her, a couple of us were there. I said, all right. So she was treating him, looking after him. And you won't believe it, on the 5th day, I went to pick up his CBC in the evening with my luck. What do I find? A WBC of 1 lakh something. Most of them were blasts. And I caught my breath. And I called another senior over. I said, take a look at this. So let's call Dr. Kunrad if she's around. And luckily she was. She took a look at the slides and she looked at us. And she says, what did I tell you? He's got it. So I think he says, I will have to do a bone marrow. So I was hesitating to do the bone marrow because I thought if I did a bone marrow, this could happen. And he was into acute anemia, leukemia. He was into acute anemia, normoblastic leukemia. And you won't believe it, on the 3rd, 4th day when this happened, his mother got admitted. Same thing, CBC abnormal, she was admitted, and she had a count of about 80,000-90,000, left shift complete, blasts. So the son was in one room, the mother was in the other room, and both died 2 days later. And this really shocked the hell out of us. We've never had a case like this. And since I remember this, I am telling you that this can happen. Not always, but can happen. And I have seen this happening in front of me. And what was it, 24, 25 was engaged to be married. And the mother was not very old, married. The mother was about 40, 50, 60. Both died on the same day. Alright, we'll continue. Coming back to aplastic, stem cells are damaged. As a result, the bone marrow is either empty, aplastic, no cells, or contains few blood cells, hypoplastic. You've got the names, I hope. The most common cause of aplastic anemia is from your immune system attacking the stem cells in your bone marrow. So some sort of a current supplied to the marrow. Other factors that can injure bone marrow and affect blood cell production include ionizing radiations, here we go, drugs and chemicals. And this boy who died, who was in the army, was working at a research facility for the army, and he was exposed to these toxic radiations. Toxic chemicals such as used in pesticides and insecticides, and benzene, an ingredient in gasoline, have been linked to aplastic anemia. So here we go, essentials of diagnosis: pancytopenia, no cells, no abnormal cells seen right now. Hypocellular bone marrow, the bone marrow is empty, you can see it on the right hand side. And again, you can see it, take a look at the slides on the right hand side. The macrocytic, the hypochromic, some are microcytic, and poikilocytosis is present. Use of certain drugs, I'm repeating myself, antimicrobial drugs such as salvarsan, chloramphenicol, sulfonamides. And I think now we have, why doctors have banned giving chloramphenicol with typhoid. because of this. And we've switched over to better drugs. Anticonvulsants such as mesenterin and so on, analgesics, phenibut, antithyroid drugs, antihistamines, insecticides, DDT, and other chemicals such as mercury and gold compounds. Treatments for aplastic anemia include medications, blood transfusions, or stem cell transplant, also known as bone marrow transplant. We're continuing with the aplastic anemia. You can take a look at the smears. You can take a look at the bone marrow. It's hypocellular. You can hardly see anything there. Marrow cellularity is less than 25%. Severely reduced hematopoietic stem cells, precursors in bone marrow. You can see it's not a good picture. Then we come to sickle cell anemia. Sickle cell anemia is also known as sickle cell disease. Sickle cell anemia is an inherited red cell disorder in which there aren't enough healthy red cells to carry oxygen throughout the body. Normally, the flexible round red cells move easily through blood vessels. In sickle cell anemia, the red blood cells are shaped like sickles or crescent moons. These rigid, sticky cells can get stuck in the small blood vessels, which can slow or block blood flow and oxygen to different parts of the body. And you know that this is an inherited type of anemia due to hemoglobin S. So, SCD, homozygous hemoglobin disease, is a serious chronic hemolytic anemia, often manifests in early childhood and is fatal before the age of 30. Now no more, there are treatments for it, and as you can recognize it early, kids are saved. The amino acid glutamic acid in the 6th position of the beta chain is replaced by valine due to this changes in the electrophoric mobility is observed. So like I told you, you would have to go in for electrophoresis and you will find out what is happening to this hemoglobin. Hemoglobin S is soluble when fully oxygenated, and when oxygen is removed from HbS, polymerization of abnormal hemoglobin occurs, forming tactoids, which are fluid crystals which are rigid and deform the cells. So like I told you, hemoglobin S is genetically inherited, and you can take a look at the biochemical changes. Yeah, hemoglobin, you and I are alpha to beta 2, right? But here what happens with beta, you've got a change in the 6th position replaced by valine, glutamic to valine. In homozygous sickle cell disease, sickling occurs in physiological oxygen tensions, and the rigidity of the red cell is responsible for hemolysis and most other complications. The rigid cells are vulnerable to trauma and are trapped by the reticuloendothelial system, especially by spleen accounting for hemolysis. And this is, as you know, we are labeling it to the African Americans, but let me tell you, we in India also have sickle cell. Usually it is present in the Adivasis who live in the hills, and it's a little different genetically, but I have come across in Gujarat sickle cell in a fairly good number. Okay. So this is what it does to you. As a result of hemolysis, severe hyperplasia during childhood produces bone marrow changes, expansion of narrow spaces, thinning of cortex, and radial striations are seen in the skull on X-ray, and leg ulcers are common because the circulation is bad. In early childhood, bilateral painful swelling of the dorsal, upper side of the hands and feet is observed, which is known as the hand-foot syndrome or sickle cell dactylitis, sausage-like inflammation of the fingers. Symptoms. Signs and symptoms of sickle cell anemia usually appear around 5 months of age. They vary from person to person and changes over time. The signs and symptoms are anemia, frequent infections, delayed puberty, vision problems, and so on. Fever. People with sickle cell anemia have an increased risk of serious infections, and fever can be the first signs of infection. unexplained episodes of severe pain, such as pain in the abdomen, chest bones and joints, swelling in hands and feet, abdominal swelling, especially if the area is tender to touch, pale skin or nail beds, yellow tint of the skin or whites of the eyes, signs and symptoms are there. So you can take a look. There's a solubility test also. There's a special solution that is used. If the person is normal, when you mix your red cell into the solution, you can see the clearing and you put it in a special rack. Clearing of the lines below tells you that hemoglobin A is present. Whilst if there is no clearing and the solution appears to be turbid, chances are that this is sickle cell positive. So treatment will include medications and blood transfusion. Some children and teenagers, a stem cell transplant may cure the disease, and medications are mentioned up here. So the second most important we'll look at inherited is thalassemia. Alpha 2, gamma 2, that is on, we take a look at, because you and I are alpha 2, beta 2, this is alpha 2, gamma 2. It's an inherited disease of hemoglobin synthesis. It is due to impaired production of one of the polypeptide chains of hemoglobin. That is, the rate of synthesis is diminished, but the chain formed is structurally normal. Beta thal is most common, which is caused due to impairment of the beta chain. The primary genetic defect in beta thal is either unstable messenger RNA, mRNA, or a deficient production of normal mRNA, which is responsible for directing beta chain. Other disorders are alpha, beta, delta, all different types of thalassemia combinations are occurring. And take a look at the smear. You've got hypochromasia, you've got target cells. You can see the red cell with a little bit of hemoglobin in the middle. You've got poikilocytosis, you've got some schistocytes, and so on. So beta thals can be either a major or minor. Thal major is known as Cooley's anemia or homozygous, having two identical alleles. Minor thal is also known as Cooley's trait or heterozygous, having two different alleles. Thal minor. Thal major, severe hemolytic anemia with jaundice and splenomegaly. Enlargement of the screen is evident in early childhood. Prominent facial bone and slanting eyes give a mongoloid appearance. It is hypochromic microcytic anemia caused due to defect in heme synthesis. Alright. You can take a look at this girl's picture. Low nasal bridge, small head, and so on. So here we take a look at the electrophoretic pictures, and this is the best way to prove whether there is an inherited anemia. So blood picture and electrophoretic pattern, reticulocytes, extreme poikilocytosis, target cells, ovalocytes, Cabot rings, Howell-Jolly bodies, siderocytes, and anisocytosis and extreme normoblastosis. Please look up, I think some of these meanings, some of these pictures you already have. Osmotic resistance of red cell, serum iron and indirect bilirubin increase. Normal marrow shows normoblastic hyperplasia, and inclusion bodies are observed after staining with methyl violet. Thalassemia major is true beta thal, HF, hemoglobin F 40 to 60% may go up to 90%. Hemoglobin A is undetectable. Hemoglobin A2 is increased. The ratio of A to A is also increased. So you can take a look at the different electrophoretic patterns, and this is what we take as the gold standard. Then you come to thal minor, which is getting to be quite popular these days, and especially like I think in the last lecture we said we do counsel people who have thal minor, especially before marriage. Minor thal varies from moderately severe anemia to completely normal findings. There is a mild hypochromic microcytic anemia with slight jaundice and splenomegaly. Usually there is no anemia, red cell count is elevated, hemoglobin, hematocrit are decreased, MCH is low, MCV is usually low, and MCHC is low, but often normal. On blood films, microcytosis, poikilocytosis, target cells, and basophilic stippling are observed. Serum iron is normal or high, HbF is slightly increased to 50%. In cases 2 to 6 range, hemoglobin A2 is increased in 3.5 to 7% range, and remaining is HbA. So here you have a mixed cell population that you can see. So thal minor, like I said, goes undetected. You can it is of we patients come to us and our parents say, oh, she's little anemic, her hemoglobin doesn't go over 8-9 grams, and that tells you that some care should be taken, especially if the girl is about to be married or is married. That's the time doctors order these tests, and if she's thal minor, then we tell her that please, if you have your partner, you're getting married to somebody, have his thalassemia electrophoresis done, because chances are that he's also thal minor, chances are your baby will be thal major. This is genetic. And you can take a look at the basophilic stippling in the middle picture. You can see the red cells and you can see the blue-black stippling. Take a look at the other morphologies also. And then you come to the famous G6PD deficiency. I'm sure you all know about it. It's present in India, it's present in us Parsis, and it's present in a lot of Italians. It's also present in the Vietnamese population. Little different on the genetics. So G6PD deficiency is also called as phavism. That's a bean which gives you Ulysses. There's X-linked, a trait where a gene is located on the X chromosome. Recessive disorder, mainly expressed in hemizygote males and homozygote females. It is drug-induced hemolytic anemia. In this, when RBCs are exposed to redox compounds such as anti-malarial drugs, sulfonamides, nitrofurans, analgesics, vitamin K, fava beans, and so on. So what happens is they are not able to generate reduced form of NADP, ultimately increasing oxidative stress on the cells. G6PD deficiency has beneficial effects, that it confers resistance to malarial parasites. And this is what they found in the African American population. And this is one finding. But like I said, especially in our country, it's there. And I think I told you about, this is in my family, not on my side. I had a young cousin who came to see me in America. He was maybe 10, 11 at that time. And we had lost his elder brother a couple of years ago. And they said he had jaundice, etc., etc. So when this boy walked in at JFK and I went to receive them, the whole family, I found this yellow-looking, puny little cousin of mine. And my aunt says he's not well, so doctor gave him some medicine before he came here. What I did was I took him to the apartment which I was renting from a friend of mine, and I said, first thing I gave him a little paper cup. I said, Didi, show me your urine. And the urine was brandy colored. So I knew something was wrong. So I said, forget, we'll see, take a look at New York later. I just dumped them in my car at 5 o'clock in the morning and drove them to North Carolina and drove them straight into the emergency room towards afternoon. And I said, just do a CBC on him, etc. So the CBC was not very good. His bilirubin was high. Most of it indirect. So I was advised by the doctor, they said, Ruth, take him to Dr. Arthur Landon. And Dr. Arthur Landon, who is, I think he's still alive, one of the best pediatricians America has. He was not on campus that day, so at about 4 o'clock I took an appointment and I took him to see Dr. Landon with what results I had with me. And he examined Zavir and he looked at him and he looked at the report and then he's telling me, Rose, Parsi Zoroastrian? And I nodded my head. He says, don't you know you guys have a 13% positivity? He says, go back and have his G6PD done. I rushed back and he was completely deficient. So now we presume the younger brother, the elder brother who had died some years back, also had the same thing. So I told my uncle and aunt, I said, when you go back, let's have your test done. But let's enjoy right now. He says, what you can do, just make him relax, eat well, take him around, show him North Carolina, which I did. We took him around New York also. When I went to drop them, I gave them 2 days of New York. And I told my uncle, I said, take him straight, have him have all of you examined. So my uncle and the other younger son had themselves examined, and they were normal. So we knew it was coming from my aunt, female, and she wouldn't listen. There's a lot of story behind it. It was only some years later when she had a very bad chest problem. She died of that some years later. My mother was with her, and she told the physician that there is a history of G6PD in the family. So the doctor immediately told my mother, tell Rosemary to do a G6PD on her, I'm sure she will be deficient. So I did it, and she was deficient. And I knew that it would be because her brother's family is completely G6 deficient. And it's sad that this happened. Anyway, but if you were to see my cousin now, you'd never know that this boy nearly died. He's in Canada, doing very well, married with a child, and he keeps away from certain drugs. And he's mostly, when he came back to Mumbai, it was my uncle treated him mostly with homeopathy, and he did well. That's the story. Okay. So deficiency, males are more danger than females, as is inherited by the mother. G6PD is required to maintain the cell wall of the RBCs intact and maintain iron in the ferrous state, Fe+2. If it is absent, the presence of the oxidant group will change the iron from ferrous to ferric. Deficiency of G6PD limits regenerations of NADPH due to its oxidative denaturation of hemoglobin occurs. G6PD is highest in young cells and decreases as the cell ages. Okay, and we at our hospital we have a 30-bedded hospital, and we have G6PDs every day because most of our patients are Boris, and what has happened is there's a consanguineous marriage. So all the babies that are born here, G6PD is compulsory, as is G6PD compulsory in all Parsi babies born in Mumbai today, or anyway for that matter. Okay. Just a moment. In blood form, you will see poikilocytosis, irregular contact cells, and occasional spherocytes may be found on supravital staining. Heinz bodies will be observed, so this is staining in the living stage. It mainly requires to maintain NADPH levels in dead cells, which in turn is required to keep the glutathione in the reduced form. So this is again a whole biochemical reaction. It protects RBCs from oxidative stress. G6PD is mainly associated with neonatal hyperbilirubinemia that may cause kernicterus, and kernicterus can damage your cells. It loves fat, is lipophilic, and is known to lodge in the brains, and it can also cause death. It can be tested by Heinz body test and dye decolation test of Notlowski. The principles of tests are listed here. You can take a look at it. And Heinz bodies are inclusions in the red cells. It's a supravital test. And here you have the dye decolation test. So what is done is a desiccated dye is in your vials. You have to reconstitute it with a puffer, and then you have to add a certain amount of blood, and the blood is first sliced, and a certain amount of the sliced blood is added into the dye. A little bit of paraffin is layered on top so no air enters, and these tubes are incubated. And you can see the tubes A, B, C, D and E, F are normal. Yeah, the dye has disappeared, and you've got the pink color of the lysed blood bag. Whereas in E, you can see the color is bluey green. There is no decoloration. So this is the principle of the test. The normal decolorization is 30 to 60 minutes. Deficient is 140 to 24 hours. Carriers between 90 minutes and several hours. So here we come to hemoglobin formation and breakdown. We've taken a look at it, and it's quite interesting. So I won't go too much into detail because we can do it a little later. We've done it. So you've got the red cell, hemoglobin molecules, you've got oxygen to the lungs, you've got oxygen bound with hemoglobin, the red cell, and then you've got the main function of the red cell is to give off oxygen. And here you've got the heme synthesis. So you've got succinate coenzyme A plus glycine to give you alpha aminolevulinic acid, and this continues to give you copropipenogen 3. It takes place in the mitochondria. I'm not going to every step right now. So then you have the big breakdown, which becomes equally important, because many times I ask, especially a young tech who comes to me, where is bilirubin? How does bilirubin come in? And he or she usually tells me it comes in from the bile. They are not taught about the breakdown of hemoglobin, and you can see it here. Hemoglobin is broken down. Hemoglobin, so it's hemoglobin is heme and globin. Heme is broken down further to give you iron, which goes in the iron pool. Globin is protein broken down to give you amino acids. And then you've got the breakdown of heme to give you bilirubin. So the ring opens up because your bilirubin is a ring structure. So it opens up, heme opens up, protoporphyrin opens up, it gives you bilirubin. Here the bilirubin is of the indirect type. Then the bilirubin is attached to albumin, it travels to the liver. A part of it is converted to direct because your bilirubin has what is known as a 2,3 UDP, which converts a part of indirect to direct. And most of it is got rid of through the biliary tree out to the intestine. And this is what gives the stool the brown color, stercobilin. A little bit is regurgitated back into the blood. And you can take a look at the other structure here, hemoglobin broken down to heme. So you've got heme oxygenase, and here you've got how it is broken down completely to give you bilirubin and so on. So we come to the most common test that we have in the lab is the principal estimation of hemoglobin by Drabkin's method, and your Drabkin's method is a gold standard in the way. A little differentiation does take place in some machines, but this is it. You can take a look at it. So when blood is mixed with Drabkin's reagent, which is potassium cyanide, potassium ferricyanide, and the reaction takes place, you are measuring this at 530. I'm not going to go into details, all right? I'm sure. And then you come to indices. And this is what tells you about the type of anemia. So these are mathematical formulas which you should know. MCV, MCH and MCHC. The formulas in front of you. So MCV is PCV upon red cell into 10. So MCH is hemoglobin upon red cell into 10. And the normals are given to you below. MCV is 78.2, 97. There may be a little fluctuations in certain bits. So we've got mean corpuscular volume is a measure of the size of the average red cell. Anemias are characterized as microcytic, less than 80, macrocytic, more than 80. MCH stands for mean corpuscular hemoglobin, and MCH value refers to the average quantity of hemoglobin present in the single red cell. Hemoglobin is a protein in your red cell that transports oxygen to tissues of the body. pregnancy, blood loss, weight loss, etc. can cause a drop in your iron levels and leads to iron deficiency anemia or low hemoglobin and MCH values. So, to differentiate anemias, we take a look at the indices, and all your machines print this out for you. And then you've got MCHC, that is mean corpuscular hemoglobin concentration, the measure of the average concentration of hemoglobin inside a single red cell. The reference range for MCHC in adults is 33.4 to 35.5 grams per deciliter. If your MCHC's value is below 33.4, you have low MCH. Low MCH values occur if you have anemia due to iron deficiency. It can also indicate thalassemia. A high MCHC value is often present in conditions where hemoglobin is more concentrated with your red cells. It can also occur in conditions where red blood cells are fragile and destroyed, leading to hemoglobin being present outside the red blood cells. Example, autoimmune hemolytic anemia, hereditary spherocytosis, and severe burns. So this is the formula: hemoglobin upon PCV into 100 is your MCHC, expressed as a percentage. And then we come to automation. I'll leave that to Jaldeep as well as Sandhya to tell you more about it. So, your manual CBC would take you half an hour to 45 minutes. This baby up here does it within the hour. So you have a 3-part machines, you have 5-part machines, 6-part machines, and so on. So a complete CBC is typically the first test required by the physician to evaluate a patient's general health status. For such screenings, automated hematology and analysis are frequently used in addition to frequent blood levels of platelets, red cells, and so on. Although a 3-part hematology analyzer provides sufficient information for most clinical settings, trends show an increased interest in 5-part instruments, while 5-part analyzers can offer more detailed information on the white blood cells. 3-part instruments can offer great cost benefits. Both analyzers are fast and accurate. And if some of you want to come to the lab, you can see that in your 3-part, you will have everything on the red cell, indices, and so on. But on the WBC, you will only have 3 parts of a histogram. Okay? So you have the neutrophil, you have the mixed population, and you have the lymphocyte. Whilst in your 5 parts and 6 parts, you get a complete division of not only the histogram, the scattergram. So we've got 2 people here who are going to tell you more about that in the coming weeks. So these are your normal values in red cell counts. Okay? Right? Then you've got certain prefixes, suffixes that we use. So an means without, chrome is color, and so on. Aniso, unequal, baso, blue, and so on. You can take a look. I'll leave this for 2 minutes for you to study. I don't want to disturb you. Take a look. So you've got certain prefixes, and dash something is a suffix. And we in the hematology lab use these terminologies very often, or when we talk on the phone also with the doctor, these terminologies are used. So you've got again the usage, micro, small, plastic to form, and so on. Take a look at that. Meaning, hematological usage, meaning, hematological usage, and meaning. Quite interesting. Take a look at it. Alright? You have the presentation with you, and you can take a look at it, and that's the end. Any questions? For most of you, this is a revision. I know some of you have forgotten. We've got 2 experts sitting here. You can ask them questions. Yadit is here and Sandhya is here. Any questions? Parul? Urvi? Shagufta? Mahesh, Meena, anybody? Jadeep or Sandhya, you want to add to this? You want to say something with your experience?
I guess you have covered pretty much most of it, so nothing to add.
Sandhya?
Quite exhausted.
No, because Jaldeep, they've done over, I think, 7, 8 turns. We've been using, we're talking in terms, a lot in terms of the red cell, white cell, and platelets. Here, I think we dealt mostly with the red cell, right? So, and we are going to give them a test a little later on. So let's see how they work out. Sandhya, what about you?
So good to see you, Sandhya. And I love that Kerala mask in the background.
Bolo.
It was like very covered. I just need to ask them, maybe as a group, whether they are comfortable with the basics in histograms. Because based on that, I will then prepare myself for the next session that we have.
Sandhya, coming to automation, let me answer that. I'm sure many of the others would want to answer also, so we'll take their feedback. But I would suggest go for the basics because I think automation is something, unless they have actually been specifically taught by a corporate or a manufacturer, it's something usually I've seen a lot of people who think they know, but they are not really sure about it. The clarity is not full. So probably I think go start with the basics if you have the time. I think we have a time limit also because it's only 1 hour that we need to cover. So depending on that, you could take that. But yeah, I leave the question to the others to answer because you asked me to the others. And one thing for everyone before you start logging out is that during my lecture, I would request all of you to switch on your cameras and be interactive. And it's because I cannot, ma'am is very, experienced. She can talk to a wall and it feels like I'm talking to a wall. And for me, I need to see people, I need to see your faces, I need to see the expressions, and I need to see whether you are understanding or not. So based on that, I would request all of you. So on the 17th, when my session is there, or probably Sandhya's session also, I think I can see Sandhya also agreeing to that. So please keep your videos on. So prepare. So you can plan your day in such a way. If you're taking it from your bed, probably, like me, take a minute to set your hair before you come or switch on your camera. So be ready for the camera on 17th and 24th. Are we good with that?
Should be.
Yes.
Okay.
Yeah, sure.
And keep your microphones on 17th because I would want, it would be very interactive and I would be asking questions and waiting for the answer. So, just so that there's no delay in the responses because you wait for a unmute. Unless, of course, you are in a very noisy environment, there's a centrifuge or a blender in the background, then it's okay, you can switch off. But otherwise, I would request all of you to keep the cams and the mics on.
Yes, sir. And Sandhya ma'am, like it would be very nice if you could teach the basics because the people like us who have been out for a very long time. So it will be very helpful, ma'am.
Yes, I agree to that because even I would want it very basic.
Yes, ma'am. We are out since a long time. So thank you. Yes, ma'am. Thank you.
Sandhya's really good at the histograms and the scatograms. She's a master. So, sorry? No, but yeah, she's good. I promise I'll attend, so I'll be there.
No, because told me he wanted to attend today to see what it's like. I said this is the way we've been doing it, and then the last sessions is very interactive. We talk to each other. Nazneen's not there today. Where has she disappeared? I don't know. She talks quite a bit and she's not very. Jaldeep, she's the one who is in Dubai,
Okay.
and she is one of the managers in quality control and all. So she comes up with some very interesting data and facts. So she's not here today, but I'll make sure she's there for your sessions. Maybe she's busy or she's driving, which she usually does, and then she connects from the car. So that may be a problem. A couple of them have told me they would not attend because they're out for Mohram. And Gautam Bhai told me, Gautam Bhai is one of our most senior people. Jaldeep, you may be knowing him, Gautam Desai. And Sandhya, you know Gautam Desai. He is quite active with the association.
I'm not sure.
Yeah. So his daughter is shifting to a new house. And he's saying, Ruzbay, I don't think there's any internet connection there, so you'll have to accuse me. Very senior, very senior. Very senior. Okay,
If he wants to attend and there's no internet, he could probably take it from his mobile phone.
That's what I told him, but he says, we're shifting, we're in between trucks and all that, so I don't want to be involved in that. I told him that.
Yeah.
Anything else? Can we wind up? Chalega?